describe interventions to relieve those common discomforts and identify the crucial elements of assessment related to nursing. We will also talk about patient education. So, how do we assess pregnancy? There are physiological changes that happen in pregnancies. There's components to antenatal care, and there are some nursing actions that we want to talk about. So the woman's health and preconception care is to identify potential risk factors. Just about every organ in the body is going to be affected by pregnancy. So there are some reproductive changes. There's changes in the breasts because there's preparation for lactation, which means they will grow, they'll become more tender, they will have more blood supply, and possible leaking of colostrum late in pregnancy. What happens to the ovaries when the woman's pregnant?
No more ovulation.
Right. There is no ovulation, right? The ovaries have done its job. Ovulation has occurred and fertilization has occurred. So the ovary does not continue to push out eggs. Okay? This is one of the reasons why they say pregnancy sometimes is a protection from ovarian cancer. Okay? Women who have had pregnancies are at a lower risk of ovarian cancer than women who have never been pregnant. Why?
Is it because of estrogen?
Kind of. It's because the ovary never takes a break. And someone that's not pregnant, that has just been having cycles and cycles and cycles and cycles, the ovary never gets a break, right? The ovary gets a break for 10 months during pregnancy, right? Because it's not spitting out eggs.
How do you feel about the birth control that stops your period? Would that help or no?
Birth control does help to reduce the risk of ovarian cancer. Absolutely. Because we are stopping ovulation. Now, just know that if you have birth control, any birth control can make you not have periods depending on the dose and how you take it. Okay? So just remember, birth control works because it stops ovulation. That's how it works. Okay? You only have a period on birth control because you have a pill-free week, right? So that withdrawal of the progesterone, once again, when you go back, when you understand the menstrual cycle, then you understand how birth control works. Withdrawal of progesterone is what stimulates the bleed. Okay, that's why the birth control has those dummy pills or sugar pills at the end. But if you skip those sugar pills and just start your next pack, you're not going to have a period because you never withdrew yourself off the medication. Yes.
With progesterone only, though, they don't. It doesn't have a placebo week, right?
Plus progesterone only pills?
Right.
Correct. They don't have a placebo week. But the thing with progesterone only pills is that you have a higher risk of getting pregnant over the combination. Okay, you gotta take it at the same time every day and not miss a pill. All right. Now, the uterus grows and stretches, the cervix becomes more vascular and a mucus plug forms, and the vagina has changes also. So table 4.1 is very important and is a summary of major changes in pregnancy. 4.1. So what 4.1 does is it puts everything in a table for you, and then all the rest of the pages will describe what's on 4.1. Okay, so I really like 4.1. Fundal height, this is something you kind of went over in lab. So as the fetus grows, You can see here, this is 8 weeks, 12 weeks, 16 weeks. The umbilicus is 20 weeks and on up. Okay. So what are the cardiovascular changes? There's hemodynamic changes, anemia related to hemodilution and iron deficiency. So it's a double whammy. So more diluted because there's more fluid. Body needs more fluid. And then baby needs iron to grow. So you have hemodilution and you have iron deficiency. There's a slight increase in white blood cell and there's hypercoagulability. Okay. So the hemodilution is due to a 40% increase in plasma volume. And the white blood cell count goes up a little bit, but it's not because of infection. It's just a physiological increase. There's increase in cardiac output, plasma volume, and oxygenation. So the first trimester, you may see a decrease in blood pressure, and then after, you may see a slight increase, or a return to baseline. So in the second and third trimesters. So in the first trimester, you may see a slight decrease and then return to baseline. Now, if it starts to go up, then we call that pregnancy-induced hypertension. Okay, there's increase in volume by 40%. So when their volume goes up, that means the heart has to work harder, right? Because it has more fluid to pump around. This is why the heart rate goes up a little bit. You will see edema, hemorrhoids, varicose veins. The heart does enlarge, and there may be some murmurs, again, due to more fluid on board. Respiratory changes, physiological and anatomical, right? So there's an increase in O2 consumption because now mommy is basically breathing for 2 people, need more oxygen. So that was going to increase the tidal volume and the respiratory rate. The body is amazing. It compensates so well. Decrease in lung capacity as that fetus grows. And the hormone, especially progesterone, is the hormone that causes shortness of breath and congestion. Especially progesterone is the one that causes the epistaxis. Does everybody remember what epistaxis is?
Nosebleeds.
Nosebleeds. Yep. And that congestion. Here's the displacement of the heart and the lungs. Okay. Now, supine hypotension also affects circulation, lower extremity swelling. And this is why, what's happening when a woman is laying flat on their back?
It's compressing the vena cava.
Yes. Okay. So this is why whoever was in labor and delivery, did your patient have a wedge? Who was in labor and delivery? Okay, this is why patients have wedges. Because what happens if we make mom hypotensive? What happens to the baby?
The baby's not getting oxygen.
Exactly. Everything we do to mom will directly affect baby. Renal adaptations, mild proteinuria, mild being the operative there. Increased GFR. Frequency, urgency, nocturia, incontinence. Now, I'm not necessarily talking about incontinence like they have to wear a incontinent pad or they have to be in diapers, but that incontinence that can happen from something always pushing on your bladder. So if they cough, sneeze, a little bit of stress incontinence, right? Anatomically, think about how that baby is growing. Nausea and vomiting, most resolve at 12 weeks. Cravings, does anybody know what pica is?
Non-edible
Usual
food.
stuff.
Eating non-edible food. Eating non-edible substances. Dirt, chalk.
Ice.
Uh-huh. What is tylism? Does anybody know what tylism is?
That's the increase in saliva.
Correct. So you'll see some women have increase in saliva and they'll bring a spit cup with them. And all they're doing is just spitting because they can't always find a sink. So instead of spitting on the floor, or spitting wherever, they have a spit cup and they'll spit into their cup and then they'll throw it away. Okay. Slowing of digestion, so that can cause heartburn, constipation. And so you got constipation and you got anemia. So pregnant women hate to take their iron pills because it makes them more constipated, right? The other thing is if you see someone that has really bad pica for ice, assume that they are anemic. It's just most women who have really bad pica for ice, like they come in with like the 7-Eleven cups of ice and all they do is chomp on it. We don't know which one causes which. Does the ice cause the anemia because they have so much ice that they can't absorb any food? You know, their stomach is so cold and their stomach is always full of ice, so they're gonna not have the room to eat the iron-rich foods. So is the ice causing the pica? Or, I mean, ice causing the anemia? Or is it because they have anemia makes them crave ice? We're not sure which one it is. But if you see a woman that is just chomping on ice all the time, it is pretty safe to assume that they are anemic. Musculoskeletal changes, the lordosis that occurs in the spine as the abdomen grows. Round ligament pain is very common early in pregnancy. Women who this is their first pregnancy, they have this lower pelvic pain. They think they're having a miscarriage. Most of the time, it is the round ligament pain. Joint pain and instability from progesterone and relaxin. So it makes their joints very flexible. And that is there so that their pelvis can move and flex as they're having the baby, but it affects all their joints. Okay, so not only do they have an off center of gravity as the abdomen grows, but their joints are also lax, so they're more prone to falling. There are some, let's see, hyperemesis. So hyperemesis is extreme nausea and vomiting. These are women that have to get PICC lines, have to be in the hospital, have to get TPN. Okay. There are some related to gastrointestinal and pica and all that stuff in the mouth. There are some studies that show that gum disease, so really bad dental gum disease increases the risk of preterm labor because those bacteria get into the blood. Blood, we know, crosses into baby. Skin changes, striae, which are stretch marks, hyperpigmentation, we call that mask of pregnancy or melasma. They get a very dark neck. Acne, endocrine adaptations, there is an increased thyroid hormone need for thyroid hormone. So the rule of thumb is there's increased demand for thyroid hormone. So the rule of thumb as far as providers are concerned, not for you to prescribe, but maybe you may need to remind somebody. If someone is already hypothyroid and they become pregnant, they need to increase their thyroid medication. The provider should be increasing their medication just right off the bat. You don't want to wait for them to become hypothyroid because that's going to affect the baby. So, if you are already hypothyroid, they are going to increase your thyroid medication just right off the bat. The immune system, many complicated changes happen because what is the immune system supposed to do?
Protect.
You.
And attack anything that's foreign, right? Would a fetus be considered foreign? Yeah,
Yes.
technically, a fetus is considered foreign, right? Half of that genetic material is not yours. So how your immune system is smart enough to figure out that it doesn't need to get rid of the fetus because and grow, allow the fetus to grow, that it's very complicated how the immune system changes. But just know that every pregnant woman is considered immune compromised. Every pregnant woman is considered immune compromised. Every pregnant woman is considered immune compromised. These are stretch marks, striae gravidarum. All right, this is all of the above. We're running low on time. So what cardiovascular changes occur during pregnancy? And we talked about this. Increased cardiac output, dependent edema, increase in plasma volume, the heart grows, multiple things. Preconception care. So education and anticipatory guidance are one of the best things that nurses can provide for preconception care. So we are really good at identifying social, behavioral, environmental, or biomedical risks that may affect a woman's fertility or a pregnancy. Half of the pregnancies in the United States are unplanned. Half. Okay? So nurses play a role in risk assessment, education, and anticipatory guidance. We encourage routine screening, routine prenatal care, information on nutrition. These are all the things that we can provide. So how do we really know if someone's pregnant? And this is broken down into 3 categories: presumptive signs, probable signs, and positive signs. So the positive sign is only attributed to a fetus. So meaning there's nothing else that can make us doubt that a fetus is not causing whatever symptoms or whatever sign it is. So if a mom says she feels the baby move, she feels like something moving in her abdomen, is that enough for us to say that someone's pregnant?
No.
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 It could be something else, right? But if they put an ultrasound on and they get a fetal heart rate, is that considered a positive sign?
Yeah.
Okay. Presumptive signs are all subjective signs of pregnancy. The changes are perceived by the woman herself. Amenorrhea, meaning no period. We know that that could be something else. Nausea and vomiting. Maybe you ate something bad. Breast changes, that could be related to your period. That could be something else. Fatigue, maybe you're working too hard. Urinary frequency, maybe you have a UTI. So you see how these are presumptive and not positive.
And you can like psych yourself out, right? Like psychosomatic symptoms, like kind of you think that you know you're pregnant, so you'll get more nauseous, or something like that.
Right. Quickening is
What about
considered,
HCG?
yeah, but HCG is not there. But HCG could be something else too.
It can, okay.
HCG could be a molar pregnancy, and you have to find out if the woman is on HCG, right? Because people take HCG for weight loss.
Okay, thanks.
Yep. Quickening, thinking that, awareness of fetal movements. It usually happens around 18 to 20 weeks for first time, 14 to 16 weeks for women that have had a baby before. So earlier, because their body knows what's going on. But all of the signs could be caused by something other than pregnancy. Probable signs include Chadwick's sign, which is when the vagina turns a little blue around 6 to 8 weeks. Goodell's sign, which is softening of the cervix. Hagar's sign, softening of the lower uterine segment, which causes that round ligament pain, and increase in uterine size. Probable, but not positive. Hyperpigmentation, ballottement, and HCG. So here you go, Steve. See, HCG is still considered probable. It's not positive. Okay?
Yep.
Because it could be something else. Positive signs are objective signs that can only be attributed to the fetus. For example, auscultation of fetal heart rate, observation and palpation of fetal movement by the healthcare provider, and sonogram visualization. So how do we figure out when women are due? We use Nagel's rule. Please know Nagel's rule. Okay? You take the first day of the last menstrual period minus 3 months plus 7 days. I'm sorry, 3 months plus 7 days. So April, no, that's right, I said it right, minus 3 months. So April 1st, you take away 3 months, so that's 4, 3, 2, 1, that's January 1st. You add 7 days, that's January 8th, and then it's going to be 2020. So let's say this was April 2019. It's going to be January 2020. Everybody got that? Yeah, okay. If it's an unknown period, we have to do other things, physical exam, auscultation, date of quickening maybe, ultrasound, and history of assisted reproduction. So if this is a infertility patient that has now become pregnant, we actually may know the exact day that things happen. Nagel's rule only applies to women with regular cycles. So your PCOS patient that only has cycles every 4 months or every 3 months, can we use Nagel's rule? Nope.
No.
No.
Because we don't know at what point she got pregnant because she's not having regular periods. This is a little bit of review from lab. So the GTPAL terminology, G, number of time pregnant, number of infants born is T, P is preterm, A is abortions, and L is living children. Please know this. Okay. Also know nulla gravida, prima gravida, multigravida. So nulla gravida means what?
Never been pregnant?
No
Not
pregnancy.
pregnant. Not pregnant. Prima gravida means
First time.
first pregnancy. Multigravida, more than one. Yeah. The components of prenatal care, core 4 on page 79. We're going to talk about first, second, and third trimester. So the first trimester, you're going to have some labs done, screen for STIs. Nutritional assessment is important during this time. H&P, IPV screen is intimate partner violence, okay? Pregnant women are at higher risk for domestic violence when they're pregnant. It's pretty sad. You'll see in triage they have those tear-offs for, tear this off if you need to call the hotline or whatever. We had to replace those like every 5 or 6 days because all of them would be torn off. That indicates how many women are being abused pregnant. Okay. They'll check the fetal heart rate, and the visits are usually every 4 weeks. So some of the nutritional assessment that we'll do is the BMI. So please know the BMI guidelines on page 83. You also want to tell them to avoid raw foods like sushi, unpasteurized juice or dairy. Okay. Encourage hydration. You also want to tell them to stay away from large fish. Why do you think we tell pregnant women to stay away from large fish? Like king mackerel, marlin, shark,
Because of
swordfish.
Mercury.
because of
Oh,
mercury.
Yep. Right? All the big fish eat the smaller fish, they eat the smaller fish, they eat the smaller fish. So the big fish have the highest amount of mercury. First trimester warnings include abdominal pain, vaginal bleeding, severe nausea and vomiting. Second trimester, we do the quad screen, which is Down syndrome. That's usually the time that they get checked for gestational diabetes. If they are Rh negative, that's when you would get your RhoGAM on 28 weeks. Okay, visits are still every 4 weeks going down to, every 4 weeks. Then we get into the third trimester. Warning signs for the second trimester: absence of fetal movement, vaginal bleeding, abdominal pain, persistent nausea and vomiting.
All right.
Second and, go ahead.
23 on the RhoGAM.
28 weeks.
28. Okay.
Mhm. Kick counts. We tell women in their almost like end of second into the third trimester. We tell them to do kick counts, which is 10 movements. You should feel 10 movements in 2 hours. If you don't feel it, lay down, drink a little bit of juice, lay on your side. Baby usually wakes up. Sometimes women get so busy they don't realize baby's been moving, and then they come into triage. They all rush into triage. My baby hasn't moved all day. And you get them to relax, give them a little cold water or juice, and baby's jumping all over the place. Third trimester, GBS screen, group beta strep. Gestational diabetes screen, sometimes if they fail the first one, then they may end up getting a second screening. Kick counts, visits every 2 weeks. And then from 36 weeks to 40 weeks, it's visits every week. Warning signs for third trimester are things related to preeclampsia, so vision changes, headache, right upper quadrant pain, excess edema, because we know women are going to get a little puffy, and leaking of amniotic fluid, vaginal bleeding.
What about like the varicose veins?
That's not a warning sign per se.
Okay.
Yeah.
I thought that kind of like went along with like edema.
Yeah, but in pregnancy, it just makes your varicose veins a little bit worse. And when we talk about edema, it's like not just regular pregnancy edema. When we have like swelling in the face, hands, feet, we got cankles instead of ankles. That's the type of swelling we worry about. So some common discomforts include, If your breasts are going to grow, you need a supported bra. Avoid lying on your back for the baby, and lying flat on your back is also going to give you some shortness of breath because you got this abdomen on you that's going to be pushing up. Okay, empty your bladder, wipe from front to back. Sometimes maternity support belts will help. Okay, intimate partner violence, like I said before, increases during pregnancy. So pregnant women are screened every time they're seen. You want to screen them. Okay. I did take care of a girl at Winnie that came into triage that was trafficked. And she came in with her handler, and we were able to help her out because during parts of the interview process and stuff like that, we just want mom only. Right. So, and that's when she was able to tell us that she was being trafficked. All right. Kendall, ABCD, please. Thank you. What does Nagel's rule help to calculate? The date of the last menstrual period, the estimated date for a birth, right? The GTPAL, or if they're having multiples. So that is correct. Estimated delivery date, ADT. So these are the things we went over. Does anybody have any questions? All right, let me take attendance real quick. All right, I have downloaded the attendance list. Any last minute questions?
I don't have a question, but I have a thing about the test this morning with the mirror.
Uh-huh.
So I tried to do it, but like I don't know if it was just me, but on lockdown for the iPad, I couldn't get my camera to like turn around, so it's like showing the back of my iPad, so like I couldn't show the front with the mirror. Does that make sense?
Oh, yeah. Did
Like
anybody else have that issue?
Like
I did too.
I had
And I
that
just-
issue too.
What did
What
you
I
do,
did
Keone?
was, I just, once I started the exam, I just kind of verbally was like, well, before I start, and I just held up the camera. Or I just held
Oh,
up
that was smart. I didn't think of that.
What I did
Yeah,
was
because
just
when
I
it after the environmental scan, it then turns on you, right? It turns by itself.
I don't know. It doesn't show us
At the
after,
end.
so-
I
At
know
the
how we were
end,
supposed to do
before
it.
you
So
started, it says.
yeah, for the picture where it makes you take a picture, I just like held the mirror.
You could do it then also because it may ask you to take an ID picture.
Okay.
So you can do it then too because it turns around for you to put the ID there.
Okay. Thank
Yep.
you.
You're welcome. Any other questions? No? Gone.
Thank you.
All right. You guys are all
Thank you.
set. Have a good evening.
Thank
You're
you.
welcome.
Thank you. Bye bye.
Good evening. Thank you.